So I'm going to ask Dasha, who is the Deputy Director for Policy and Advocacy at the Eurasian Harm Reduction Network based in Lithuania, and also a member of the she's also the European delegate on the NGO delegation at the UNAIDS, Program Coordinating Board, representing the community of people who uses drugs. So Dasha, I think I'm going to ask you to lead us off in the discussion.
So we start now with the presentation. Mine? Yeah. Oh, okay. Oh no, my God, I died. I'm sorry. I thought that this thing, if I press the button, it will, give me exactly 10 minutes of time. No, it doesn't work like this. I'm sorry, in my presentation, it's supposed to be there. I'm just lost. The last day of the conference, the moment when people
There it is.
usually know what's happening, I feel absolutely unprepared. Yeah, I think it's like this.
Right, perfect.
Slides. So I will be talking about the question of how we reach the unreached. And I will speak about Eastern Europe and Central Asia, and I will speak from the drug user community perspective and harm reduction. And I think these days, most people here at that conference have heard the words harm reduction, but I will spend a couple of moments just to remind you that when we speak about basic harm reduction services, we mean at least two minimum activities that we provide, services which we provide to drug users. One is needle and syringe exchange, and the second is methadone or buprenorphine treatment, which we also call opioid substitution treatment, which is treatment for people who inject opiates. So I think it's really interesting to see who we reach and who we do not reach. This is a very general slide. It's based on assumptions, and we usually, like here it says contacted people, like people who we contact, people who we reach. They're usually just a small fraction of the whole drug user community. And who are those who we do not reach? Because usually when I speak to people who are outreach workers in their cities and asking them who are your clients, they would usually say, well, usually these are people who use drugs for many, many years. They're local, they're most often heroin users in Eastern Europe, and this is not really representative of the whole drug scene, of the whole drug market, of the whole community of people who inject drugs. And if we continue with asking people whom you reach and whom you do not reach, we will see that women with children, ex-prisoners, young people, migrants, ethnic minorities, usually are not reached by harm reduction services. And why it happens? It happens very often because as outreach workers, you have people who are either using drugs themselves or have past history of drug use. And they work through their own contacts in the community, which is great. But if we do not involve women who use drugs or young people as outreach workers or as social workers, then we do not reach other segments of drug user community. But the thing is that this analysis is very rarely done in reality. It's very rarely done. And also the question is, what do we mean people contacted, people whom we have reached? When I use at the statistics which people put in their reports to the Global Fund, I see some very nice figures there. But what does it mean? Usually it means that a person has been contacted once a year, or sometimes once during the 5 years Global Fund program cycle. And a lot of these people haven't been contacted by the program. They have been reached through secondary needle exchange, which means that volunteers from the community or active clients of harm reduction program distributed needles among their syringes, and those people could have got only syringes from harm reduction service, but no testing or no counseling. So if you look from the donor's perspective, and my organization, which is Eurasian Harm Reduction Network, is not a donor, but we have one 3-year project with the European Commission, and it's a project through which we provide funding to gender-sensitive harm reduction services in 6 countries of Eastern Europe. And our main objective is to enroll 4,000 women into harm reduction services. 4,000 women who have not been contacted by harm reduction programs before. And when we work in such countries as Azerbaijan, it's very easy to find such, like most of women who use drugs have never been contacted by any public health service. And as a kind of a donor for this project, because I work in an organization who will need to report back to the European Commission, I know where my interest is. I want high efficiency, I want low unit cost, and I want clear reporting according to unified indicators. And this is how we get all these nice numbers that we have reached 60% of drug user community, just because it's, this is how we ask service providers questions. So how do we actually involve the community to improve efficiency of harm reduction programs? And I will start, I came to harm reduction program in 1998, and I came as a client. And I loved these guys. I liked what they were doing. That was great. And I said that I want to work with them, but they said that they didn't have any job positions to offer me. I said, do you have volunteers? They haven't got volunteers at that moment, like they never had before. I said, I would be a volunteer. You don't need to pay me. I just want to be with you guys. And in the 90s, it was mostly like this. People who use drugs were used as unpaid workforce for rapid situation assessments, to start harm reduction programs, and to support outreach work, which could not be organized otherwise without involving these people. In the beginning of 2000s, and that's of course generalization, because in different countries it happened differently, but in general, and maybe in other regions it happens in the same manner. We started to involve community as secondary needle for secondary needle exchange, because we wanted to have better reporting to our donors. We wanted to show better coverage of drug user community. And I would call them as unpaid outreach workers, because they were supposed to be doing the same kind of thing. In middle 2000s, we started to involve the community as paid outreach workers, as case managers, and as peer educators for antiretroviral treatment, because we had to scale up HIV treatment. We could not do it without the community. In late 2000s, we had some change. We started to involve drug user community into monitoring of access to HIV services, specifically in Russia and Ukraine and some other countries of Eastern Europe, where drug users do not have good access to HIV treatment, but government reports that there are no barriers. So we had to prove that barriers exist, and we did it through a number of networking projects. And what I'm going to focus today in the remaining 4 minutes is that today our next step should be involving the community into funding decisions in order to improve allocative and technical efficiency of harm reduction programs. And I'm going to show you now how we are, and with whom we are going to do this. Here are pictures of our main supporters, of the main thinkers, supporters, and workforce for what I will describe in a minute. This woman comes from Kyrgyzstan. She is on substitution treatment there, and she works with other women on OST. Sergei Uchaev, person from Uzbekistan, the country where civil society cannot get, any international funding, just the global fund, but somehow they try to survive. Eka Gardabkhadze, she's here at the conference. You might have seen her. She's from Georgia. She is the first Georgian woman with open drug user status. Pulot from Tajikistan, and I will be giving a couple of examples of Tajikistan, and he is the leader of drug user community who works with the government and with the Ministry of Health. So when we involve the community into making decisions about funding and composition of harm reduction services, what questions we have to ask. First of all, we need to ask what services should be added on top of the standard package to reach the unreached. You remember on the first slide, I've shown that there are, for example, women with children or young people. They probably need something extra on top of those 9+ interventions recommended by WHO. They want something else. Otherwise, they already would be reached. There are some services provided which probably should be removed. For example, there is art therapy. There are a lot of nice things which are nice to have, like, I don't know, consultation by narcologists. I don't know what it really means in reality. Legal services, such legal services which do not provide you any support for criminal cases, because in most of our countries you have some lawyer who can give you advice, but who cannot give you advice on your criminal case on drugs. People usually need, advice from criminal justice lawyers. And we also need to ask the community how to reduce costs of service provision. And there can be different kind of advice which we can get from people who use drugs. For example, we can simply change opening hours of a harm reduction clinic, and it will reduce costs, and we will be able to reach more people. So just to give you an idea how involvement of drug user community happens today. Example from Tajikistan. They're in the process of new funding model now. And we think that new funding model is a safe platform to pilot drug user involvement in funding allocation decision-making processes, because the Global Fund recommends to involve community through country dialogues. But the thing is that most of stakeholders want to have status quo. They just ask community leaders which services drug users want, and they get a whole list of services. For example, in Tajikistan, people want, on top of what they have now, they want naloxone, they want hepatitis C treatment, they want legal support, and they want expansion of methadone programs. And then the budget decisions are taken behind closed doors. So people are just asked what they want, then you have this black box, something is happening, and then what do they get? And they get expansion of methadone programs. Why not naloxone in several sites? Why not legal support? Where are gendered services? We don't know. And this is how the process happens today. So what we propose, and that would be my last slide. So what we proposed to have consultations with various subgroups of people who inject drugs, to involve them into costing exercise and to calculate how much does it really cost to organize a naloxone program in Tajikistan. Such simple exercise is usually never done. To have prioritization in consultation with community, and to really involve people in explicit rationing processes, and then to advocate together with the community for better service management and supportive legal frameworks for harm reduction. Thank you.
Thank you, Dasha, for setting the stage. I think my take-home message from your presentation really is that, programs for communities shouldn't, of course, need to engage communities, but they shouldn't just be about meeting the targets for funders, but they really should be about, meeting the needs of communities and ensuring that they're developed in such a way that communities have the opportunity to be engaged in the ways that they want to be engaged in, and most specifically that the programs address the actual needs of the communities, and of course you've highlighted, the issue around financing and adequate financing. So I think that's my take home from your presentation.